you medical students out there.
Yes, hello?
Today we're tackling something you'll definitely encounter, thiazide diuretics. We want to look at how they work and, what you really need to watch out for.
Exactly. Think of it like one of those focused sessions you might find on KMR advice.
Right. Our mission here is simple. Break down the mechanics, the important considerations, especially relevant for your studies here in India.
And we're drawing on solid medical information, really geared towards education. So let's jump in. We start with the drug itself, maybe chlorthalidone or HCTZ.
Okay, so the patient takes the pill. What happens next? Where is it going?
Well, it gets absorbed and travels through the bloodstream, eventually reaching the kidneys, specifically a part called the distal convoluted tubule, the DCT.
The DCT. Got it. That's a key area for kidney function, isn't it?
It absolutely is. It plays a big role in handling electrolytes and water balance. And that's precisely where these thiazide drugs exert their effect.
Okay, so it arrives at the DCT. What's its primary job there?
Its main action, really the core mechanism, is to block a specific protein. It's called the sodium chloride symporter. It sits on the cells lining the DCT.
A symporter. So it moves things together, sodium and chloride.
Exactly. Normally, this protein pulls sodium ions and chloride ions out of the fluid, filtering through the kidney and back into the body. Reabsorption.
Ah, okay. So the thiazide drug jams that process. It inhibits the symporter.
Precisely. It blocks it. So the immediate result is less sodium and less chloride get reabsorbed from the tubule fluid.
Right. They stay put in the tubule.
They stay in the tubule.
And what does that do to the water? I remember something about water following salt.
That's the key,
Yeah.
because you now have a higher concentration of these ions, Na plus and Cl, inside the tubule. Water tends to stay there too, osmosis.
So water gets retained within the kidney tubules instead of being pulled back into the body.
Correct. It follows the sodium and chloride.
And the overall effect on the patient then is...
The end result is the body excretes more sodium, more chloride, and importantly, more water. This means increased urine production. That's the diuretic effect. It's usually moderate, not overwhelming.
Okay. Moderate diuresis helps with things like high blood pressure, fluid buildup.
Yes, those are common uses. Now, there's also a slightly different effect happening with calcium. It's interesting.
Oh, what happens with calcium?
Well, while sodium and chloride reabsorption is decreased, thiazides actually seem to increase calcium reabsorption in that same DCT segment.
So less sodium reabsorbed, but more calcium reabsorbed.
That's right, which means less calcium ends up being excreted in the urine. Urinary calcium levels tend to go down.
Huh. That's an important detail. Okay, so we've got the mechanism. Block NaCl, symporter, and DCT. Lose more salt and water, but hang on to more calcium.
You got it.
Now, let's shift gears slightly. For us medical students, especially practicing in India soon, what are the big red flags, the side effects we must know?
This is absolutely critical for patient management. Thiazides aren't without risks. You need to watch for electrolyte imbalances. Hypokalemia is a big one, low potassium.
Low potassium, right. That could affect muscles, even the heart.
Definitely. Then there's hyponatremia, low sodium, also important.
Yeah.
And beyond electrolytes, we need to think metabolically too.
Metabolically? Like what?
Like hyperuricemia, which is high uric acid levels. That can be relevant for patients prone to gout, for instance. And also hyperglycemia, increased blood glucose.
High blood sugar. Okay, so low potassium, low sodium, high uric acid, high blood sugar. Quite a list.
It is. And that's why monitoring is just non-negotiable when a patient is on these drugs.
So what does that monitoring look like? What do we need to check?
You absolutely need regular blood tests. Checking electrolyte levels, particularly potassium and sodium, is essential. You also need to monitor uric acid levels and keep an eye on blood glucose.
Regularly. Got it. Spotting these changes early is key.
It's paramount. Early detection allows for intervention, maybe adjusting the dose, adding another medication, or sometimes switching diuretics.
Okay, let's quickly recap then. Thiazides work in the DCT, block sodium chloride return to the body, leading to more urine output. They also increase calcium reabsorption.
Correct.
But critically, we need to monitor for low potassium, low sodium, high uric acid, and high blood sugar.
That's the summary. Understanding both sides, the benefit and the potential risks, is fundamental.
Absolutely essential. And listen, for all of you following along, maybe you found this through KMR Advise. If this breakdown helped clarify thiazides for you, please share it with your classmates.
Good idea.
And make sure you're subscribed to KMR Advise for more content like this, really tailored for medical students in India. Oh, and hit that bell icon so you don't miss future updates. This knowledge is genuinely practical for your future careers.
Agreed. and perhaps something to reflect on. Considering these effects, lowering some electrolytes, raising uric acid and glucose, can you think of specific clinical situations, particularly common in the Indian context, where deciding to use a thiazide diuretic becomes, let's say, particularly complex, where that risk-benefit balance needs extra careful thought?
That's a great question to ponder, something to keep in mind as you continue your studies.